Hello, today's lecture is antidepressants and psychostimulants. In the topic on practical class, we will also have other groups of uh, pharmacological active substances like um, analeptics and adaptogens and anti-mania drugs and so on. But in the lecture, we will pay more attention on antidepressants as they are the most complicated from the whole group. Firstly, what is it? Depression. Depression, this is a mental disorder characterized by depressive traits, decrease of mood, loss of ability to experience joy, and impaired thinking. Well, as you remember from previous week, we have studied psychosis in which we had the negative symptoms. Actually, they were almost the same as the depression had. In the depressive condition, patients usually think of suicide, don't feel any positive emotions, and sometimes they don't feel anything actually, not only positive emotions but also negative emotions, they also lose. Okay, you should think about depression if 5 of the following symptoms in combination you can observe in the patient. Depressed mood most of the day, and the decrease of interest in the environment is observed for 2 weeks or more. So, what 5 symptoms of this list can be characterized as depression? Pronounced fatigue, loss of strength, disturbed sleep, the presence of insomnia or sleeping late, loss of appetite, tension in body weight, increased anxiety, indecision or loss of concentration, the feeling of uselessness, anhedonia, loss of interest or pleasure from previously pleasant like things like sports or hobbies, depressed mood regardless the circumstances, and repeated thoughts of death. So if more than 5 symptoms from this list are pronounced, that means that maybe it can be a depression. Of course, the diagnosis of depression can be given only by the psychiatric specialists, the doctor. What can be the syndromes of depression? Syndromes, they are complex of symptoms, yes, you know that. A stunning depressive syndrome, it can be is the loss of interest in life, longing, hopelessness, apathy, mental and physical exhaustion. And also it can be the anxiety depressive, the same depressive changes against emotionally explosive, fear, anxiety, and anger. So you can see that in a staining depressive we have more suppression. In anxiety depressive we have suppression with some more active pronounced symptoms. Basis of depression. Why actually all this happens? Well, the reason like initially can be different, like stress in your life or uh, like the prolonged unpleasant condition and so on. But the main pathological process which happens in your brain is reduction of monoamines in the hypothalamus and limbic system. Which monoamines? They are serotonin, noradrenaline, and dopamine. These are predominantly stimulating monoamines, and because of losing them, we have less activation in our CNS, so we have the depression. Antidepressants, they are drugs that eliminate the symptoms of depression in neuropsychiatric and somatic patients. Okay. Also, before we start talking about antidepressants, we should remember what are these MAO enzymes. MAO, this is monoamine oxidase. They are the group of thioenzymes which provide the oxidative deamination of monoamines. And MAOA is responsible for oxidative deamination of serotonin, norepinephrine, and adrenaline in nervous tissue, intestine, and liver. And MAOB, this is oxidative deamination of dopamine, tyramine, tryptamine, norepinephrine, and serotonin in CNS. So this is important information for you because we will have some interesting side effects which will be connected with this enzyme directly. Okay, and now antidepressants. They are divided into several groups. The first group is the agents which are suppressing the reuptake of the monoamines to the from the synaptic cleft. To remember this, I will draw a picture in which you can see that in the presynaptic membrane, where we have the vesicle with the storage of monoamines. Yes, here in the vesicle we have storage of the molecules of monoamines. And what do? They firstly come out from here to reach the postsynaptic membrane, but also they can from here they can also come back. And this comeback is called reuptake. So if we have the agents which suppress the reuptake, we have less reuptake, and because of that, the monoamines will be accumulated here in the synaptic cleft. Yes, they will not come back to the initial presynaptic membrane, and they will not be restored in the vesicle. Okay, the reuptake inhibitors. First group, they are inhibitors for reuptake of both serotonin and norepinephrine, which are imidine, amitriptyline, and pipophysin. Also, we have more selective drugs, which inhibit only serotonin reuptake, fluoxetine, paroxetine, sertraline, and only norepinephrine reuptake, which is mepropylene. Okay. Next, we have the drugs which can inhibit MAO, monoamine oxidase. We remember that they are thioenzymes which provide the deamination of monoamines. And what happens? If the monoamine oxidase is responsible for the deamination of monoamines, so we have monoamines, and by the effect of monoamine oxidase, they will be they will be destroyed. So if you inhibit monoamine oxidase, this process will not happen. They will not destroy it. Yes. So okay, we have the irreversible non-selective agents. Indiscriminate, non-selective, please call it non-selective, please, non-selective. They block both monoamine oxidase A and monoamine oxidase B. Yes, we remember that we have two different monoamine oxidase, MAOA and MAOB. Yes, and selective action, they block only MAOA. Why? Because if you remember from the previous slide, MAOA is more responsible for the deamination of serotonin and norepinephrine in different tissues, which are more interesting for us than the substrates of monoamine oxidase B. So that is why these drugs are more selective and more interesting for the treatment of depression, because they work for less destruction of serotonin and norepinephrine, not dopamine and tyramine and so on, tryptamine also. The atypical antidepressants, they can increase the reuptake of serotonin, for example. This is tianeptine coxyl, but not only increasing the reuptake of serotonin will happen, because this is like an opposite effect, yes, to tricyclic antidepressants. They also can stimulate directly the receptors of serotonin, which also gives the proper effect. Also, there are clinical components of action of antidepressants. Some drugs have more sedative action. The first group, yes, you can see. Some drugs have more stimulating action, the second group. And some drugs have balanced action, a little bit sedative, a little bit stimulating. Why this is important for us? Because, again, you remember, we have a stenodepressive syndrome in which patient is suppressed very much. In this case, the second group, stimulant, will be better, yes, to use. And the second group, anxiety depressive action syndrome, when patient has a lot of anxiety, and it is better to give him some sedation to calm down, yes. And balanced action can be used in both situations. Okay, now let's talk about receptor profile of antidepressants. Actually, which receptors can they affect on? The melatoninurgic receptors. Melatonin receptors, they're responsible for sleep, as you remember. Okay, so in case of insomnia with depression, it can be useful. Serotoninergic receptors, different, 5-HT2C, 5-HT2A, 5-HT3. Also, we will inhibit the transporters, and this is about the reuptake, yes, which I showed you. Reuptake of the serotonin from synaptic cleft to presynaptic membrane happens with the help of special transporters. Noradrenergic receptors. Also, we will have inhibition of transporters by which there will be more stimulation for alpha-adrenergic and alpha-2 receptors. Dopaminergic receptors, inhibition of transporters, so we will have a lot of accumulation of dopamine, so it will be again stimulated. Acetylcholine M1 receptors and histaminergic H1 receptors. So, serotonin receptors, they have really a lot of different functions. Firstly, regulation of sleep. Secondly, they can increase mood, memory, and appetite. They can stimulate the production of hormones of the pituitary gland. They are regulating the thermoregulation, and also they regulate the pain sensitivity. Actually, they can reduce pain sensitivity. Talking about the subtypes of receptors, yes, I paid attention that we can have the effect on 5-HT2, 5-HT3, and different. So what are they? The 5-HT1 receptors, they are pre- and postsynaptic membrane on the periphery and in the CNS. Presynaptic, they are responsible for the control of the release of serotonin. Yes, if we block presynaptic receptors, more serotonin will go out. If we stimulate presynaptic receptors, less serotonin will go out. Okay, so they have some negative feedback, yes, on the cell. Also, 5-HT1 receptors are responsible for constriction of intracranial circulatory vessels. When we have some headache, like migraine, for example, this can be used. 5-HT2 receptors, they are located in postsynaptic membrane of the CNS and the smooth muscles responsible for the contraction, and they enhance mental activity. 5-HT3 receptors and 4 receptors, they are in the trigger zone of vomiting center, so they are responsible for vomiting. If we block them, we can stop vomiting. And in GIT, they increase the acetylcholine release, so stimulate the contractions of GIT and secretion of the gastric juice. Nociception, this is the sense of pain. 5-HT3 and 5-HT4 receptors, they, unlike the rest receptors, 5-HT1 and 5-HT2, they are stimulating the nociception. The response of the excitation of serotonin receptors. Actually, this is what is happening in the cell. in the cells 5-HT1 receptors with the help of this biochemical reaction by stimulating the GI proteins. GI, they are membrane inhibiting protein. In the membrane, we have G proteins, which can be GI, and it means that this is inhibiting protein. So by the chain of biochemical reactions, you can see with the reduce of calcium, finally it will give hyperpolarization and inhibiting effect on the cell. Talking about the rest receptors, they are opposite. They have depolarization, they have activation of the cells. 5-HT2 and 5-HT3 receptors will be activating receptors. That's only 1 second. So, talking about these receptors and what is happening with them. When we have more release of serotonin, as we just have discussed, so with different types of action, for example, from the presynaptic membrane, the serotonin can go out and stimulate more receptors on postsynaptic membranes, yes? So, depending on what kind of receptors will be here, if it will be 5-HT3 receptors, it will lead to, by this reaction, it will lead to activation of this cell, yes? And finally, it will give us the effects. It will give us the effects from the previous slide. Here I can open it. No, I can't open it. Why? Yes, I can. If it will be in the trigger zone of vomiting center, it will be vomiting, yes? If it will be in GIT, it will be increased secretion. If it will be in the pain sensitive neurons, it will be increased nociception. So for us, this is not desirable. For us, the best way to stimulate 5-HT1 receptors and 5-HT2 receptors. And our drugs, especially from the group of atypical antidepressants, they have direct effect on stimulating these receptors. So because the drugs which are monoamine oxidase inhibitors or the drugs which are suppressing the reuptake, they have no selectivity. They effect on all the receptors. So with the activation of CNS, with the increase in the mood, you have also the side effects which can happen, like contraction of blood vessels, loss of appetite, sometimes maybe like aggressiveness, and what else was here? Smooth muscle contraction that leads to blood vessels contraction, will be high blood pressure, yes, and so on. So these drugs, they have good effect, but many side effects. Okay. About the psychostimulants. Well, we have several groups. I will erase this picture from here. We have several groups of psychostimulants. First group, psychostimulants, adaptogens. They are herbal drugs. A lot of herbal drugs we have. In different countries we have different. I know that in South we have even more psychostimulants than here in Siberia. But in Siberia we also have some psychostimulants that can be used. The second group, stimulants, sympathomimetics. They are very, very strong and dangerous. We will discuss them a little bit. And we have psychostimulants, xanthines, which is caffeine, which we all know and love. Okay. Psychostimulants, sympathomimetics. What are they? For example, it is amphetamine. You know, the drug. It is a drug which can be abused. It is a drug which can lead to drug dependence. Yes. From this drug, we have also many different like new generation drugs like ecstasy and so on. So what are the properties of these drugs? The fast onset effect after 30, 50, 60 minutes. Unlike antidepressants, for the effect of antidepressants, it takes time. It takes time like 2 weeks, and only after that there will be enough accumulation of serotonin. But with the psychostimulants and paramedics, we have faster onset. 1 hour is enough to have the effect. Okay, what will be? There will be increased physical performance, endurance in long-term loads. Increase the decay of ATP and creatine phosphate in the central nervous system. That means that our CNS will use a lot of energy and there will be not enough substrates to recover, and it will lead, of course, to the reduction of resistance to hypoxia and hypothermia. So what is going on when we have when we use such drugs like amphetamine or ecstasy? Firstly, the first step is vision, hearing, and mental performance. Like more sensitivity, it seems. Then we have search of strength, good mood, and actually this is the phase for which people are taking drugs. People are taking drugs here. In everybody says that on wars, countries, they give such drugs to the soldiers to make their performance better, to make them eat less, because these drugs, they suppress the appetite, to make them more, how to say it, like braveness, and so on, and strength, and so on. But that leads to very, very difficult, severe side effects. If you overdose, what happens? Firstly, anxiety and insomnia. Even this happens not in overdose. This happens to every person who takes such drugs. Then delirium and hallucinations. This is already the overdose, and the most difficult is depression and paralysis. It can lead to coma, actually, finally, because our cells, they cannot overwork so much. Why this happens?